You ready?
Yes.
All right. Good morning, everyone. My name is Ed Valenzuela. I'm the Siskiyou County Supervisor serving District 2, and I am currently the second Vice President for CSAC and the President of the California Counties Foundation. I'm glad to see so many people logging in on today for this very critical and timely workshop. Since its inception more than a decade ago, the CSAC Institute for Excellence in County Government, which is operated by the Foundation, has been on the cutting edge of providing best-in-class educational opportunities for county professionals. Over the years, the Institute has expanded to meet the changing needs of our supervisors, county executives, and employees at all levels of government. The COVID-19 pandemic has forever changed the way we do the business of education. I am proud to say that through the tremendous efforts of our Education Committee formed this year, the Institute has seamlessly transitioned to an online virtual platform. And that's a new experience for me, let me tell you. Even before the COVID-19 pandemic, our communities have been experiencing significant shifts in cultural and beliefs manifesting in increased grassroots activism, demonstrations, and sometimes civil unrest. County leaders are now faced with the challenge of providing culturally and linguistically responsive services to their diverse communities impacted by these events. In what we hope will become an ongoing series of workshops and sessions designed to better equip county leaders to build bridges within their communities, foster relationships across boundaries, and create consensus among diverse groups, we are delighted to present Cultural Competence, the intersection of the global pandemic and social unrest, brought to you by Pathways to Wellness African American Technical Assistance and Training Program. Here with us today, we have Nisha Becton, the founder and chief executive officer of Pathways to Wellness Medication Clinics. I want to welcome Ms. Becton here today and to also thank Alameda County Supervisor Keith Carson, who introduced us to Ms. Becton and Pathways to Wellness. Ms. Becton, please.
Good morning, everyone, and thank you, Supervisor, for that warm welcome. We are very happy to be here today, and to CSAC for thinking and considering our group to deliver this very important message and training. We are very fortunate to be here because we were given an opportunity. It looks like it's been going on, actually it's a little bit over 3 years now, that Alameda County Behavioral Health awarded us a contract to provide technical assistance and training to the community on how to properly serve and actually increase and expand our toolbox, if you will, of services to the severely mentally ill population, specifically the African American population. It's been a wonderful journey. We started off with probably 20 participants, and now prior to COVID, we had standing room only. We outgrew our actual platforms, and we increased our trainers across the United States. So we have trainers from everywhere in terms of specialty areas in which the different universities, communities have told us what they want to hear and what they want to learn more about. It's been an incredible journey. We've even had the FBI asking to participate and get training. It's been wonderful. We were recently called upon to help with suicides at a couple of the universities in California, and we went right out, we did that. So this particular area is very near and dear to me, and I'm hoping that we can share that, because as a leader, it's been very important for me to be able to deliver this message and make sure that we're inclusive. We include everybody and everybody gets to hear that message. I want to take the opportunity to introduce our trainers to you at this time and talk a little bit about this agenda that we have set up for today. We have a big agenda. We have a special message that will be coming in a few minutes from Dr. Salam, and he's one of our AATA trainers. And he's basically talking about a call for action and what we can do as leaders on the ground. So you'll hear that in a minute. And we also have Roberta Sanders, and she's going to do a historical timeline. And then we have Dr. Love, who's going to wrap it up and bring it in with what we can do, some tools, what's practical, what can everybody take back to their communities. So I want to first say Roberta Sanders, I want to talk a little bit about her. Roberta Sanders is a retired chief executive officer for Mental Health Center in Wayne County, Detroit, Michigan, in which she oversaw a huge agency, all levels, inpatient, outpatient, the whole thing for 27 years. She's a licensed social worker and a registered nurse. One of many of her accomplishments, she was appointed by the Michigan Mental Health Commission by the governor to sit on a board to help move some of the initiatives forward and integrate primary care with mental health. And we've taken a lot of items out of her playbook and have exercised right here in Alameda County. Roberta has over 27 years as a leader as well as a trainer. And so I think that you'll love to hear what she has to say. She even had the opportunity to travel worldwide and deliver trainings overseas. So I'm happy to have her. Dr. Love is phenomenal. Dr. Love is both a board certified psychiatrist as well as he's certified in family medicine. So he wears two hats all the time. On top of that, he's an engineer. So he puts together his own presentations and the crowd comes out to hear him. He has experience working in the federally qualified health centers, Lifelong, one of the big ones. And he brings a lot of information that I think that you guys are gonna enjoy. So with that, I'm gonna roll it to our call of action from Dr. Salam. This is a special message. It's sort of like our TED Talk. We call it the AATA News Alert. So this can also, you can find afterwards, I'll send it out to you guys if you want to share with staff. So thank you, Dr. Love, if you want to move, that's great.
Good morning. Welcome to the 2020 meeting of the California State Association of Counties, Institute for Excellence in County Government, and California Counties Foundation, Incorporated. My name is Dr. Kareem Salam, and I am a board-certified adult and child and adolescent psychiatrist from the East Coast, from the city of brotherly love and sisterly affection, more commonly known as Philadelphia. I pray that today's meeting is enlightening, engaging, and informative, and that you leave this meeting with more wisdom than you had when you arrived. I need not tell you we're living in perilous times, facing unprecedented threats to our climate by virtue of the warming planet. We're also facing threats in our ability to interact with each other in the setting of very deep political divisions that have occurred in the wake of our most recent presidential election. We're also facing this global scourge, the global pandemic of COVID-19. It has exposed tremendous disparities and snatched the scab off racial wounds that have festered and that have not healed. These wounds are directly linked to disparities in health, healthcare, education, housing, engagement with law enforcement, the justice system, and virtually all spheres of human interaction. The undoing of what was once normal life, what was once safe and predictable for those who were living in comfort. There's a lot more uncertainty in life in the setting of COVID-19. And for those from marginalized communities, well, some of those folks, for them at this point, life is very difficult to tolerate. Sadly enough, on this very day, more than 1,100 Americans will be diagnosed with COVID 19. I'm sorry, more than 1,100 Americans will perish from COVID 19. Equally sad is that more than 160,000 Americans will be diagnosed or test positive for COVID 19. All of us have been affected in one way or another. None of us are exempt, but we've all not bared an equal burden with the scourge of COVID 19. For example, the community I come from, the African American community, COVID cases have skyrocketed. They're nearly 3 times the rates of the white population. Hospitalization rates nearly 5 times the rate in the African American community than in the white community, and the death rates are more than twice as many. In the Latinx community, the numbers are similar. Their case rates are nearly 3 times that of the white population, and their hospitalization rates are nearly 5 times as much. COVID has affected all spheres of life. And in terms of what's happening on the ground, I work in a hospital. I work on a locked acute inpatient unit. I'm a child and adolescent psychiatrist. And typically when I go to work, I dress the way you see me dressed now, shirt and tie, slacks. For over 9 months now, I've been wearing scrubs. And more recently, given the current situation in my hospital and hospitalization and hospitals around the country, now I'm wearing personal protective equipment, PPE. I'm not an intensivist. I'm not an intensive care doc. I'm not an emergency room physician, but I have to take these precautions now so that I could increase the likelihood of remaining safe. Many healthcare workers, we've gone into this to help people, but sometimes folks, the choices they're facing at work are one between their ability to earn a living and then their ability to maintain their health and safety. So pre-COVID, you may have folks in a hospital situation, particularly in a city like Philadelphia. If you're an Eagles fan, you have more call outs on the days that the Eagles have a home game, right? But now in the setting of COVID, where people, workers, hospital workers are being affected in the setting of clinical conditions that are not changing, those clinical responsibilities and obligations have to be met by a healthcare workforce. But now that workforce is strained by this global pandemic. And so you have nurses, physicians, mental health technicians, all falling ill. You have students whose educations have been disrupted. And so you have folks who don't have the resources and the infrastructure for online or virtual learning. You have kids who have unsupervised time because their parents, who are essential workers, have to go to work and they don't have time to stay home with them and serve as surrogate teachers. And so now you have more kids in the setting of idle time. And some older folks might realize that old saying, idle time is the devil's workshop. Sadly enough, there's been a scourge of gun violence in the city of Philadelphia, particularly among the youth, that has far outstripped pre-COVID levels. Now, I mentioned earlier how COVID has affected my sartorial choices in terms of what I wear to work, and me donning this personal protective equipment is very uncomfortable. But you know what? I'll tolerate the discomfort because I want to live. Some of the kids on the unit, they pick on me on a good day. They say, Dr. Salam, you look like an astronaut wearing all that stuff. And then they may catch me in the personal protective equipment. I'm sweating and I'm breathing heavily. And they say, Dr. Salam, you're breathing so heavily, you sound like Darth Vader. Needless to say, we are facing very challenging times. And folks, I ask you, what are we going to do? How are we going to get through this? How are we going to face and surmount these challenges as a state, as a county, as a state, as a nation? How? And what I prescribe is faith, hope, and optimism in our shared humanity while recognizing the unique plight that we have coming from different communities. And though we have different perspectives, we should enlighten each other about these perspectives. And we should also work to develop and implement policy to marshal resources to uplift marginalized communities. Now, we live in one of the greatest nations in history, and perhaps one of the greatest nations on the face of the earth at this time. And the best you could ever expect from America is the best that she's delivered. And folks, I can tell you, we are much better than what we see now. We are executing very, very poorly, and we have to do better. So again, I hope that all these thought leaders in the room are committed to working hard to establish and implement policy to uplift communities that are under-resourced and to help these people who are disproportionately affected by this tremendous scourge. I thank you so much for allowing me to share time with you today. And again, I hope you leave this meeting with more wisdom and information than you had when you arrived. Take care, and I pray you have a productive meeting. Thank you.
Okay, with those messages from Dr. Salam, I hope that we all will be in that frame of mind where we'll begin to bring forward some of the tools and understanding. But sometimes before you can go forward, you need to go backwards to kind of understand how we got here from there. Let's start out by looking at a comparison of the other pandemic that we know, which was in 1918. And on the screen, you can see some numbers here in terms of the numbers of death, in terms of the time, how long that pandemic lasted, which was about 2 years. And we don't have an end date now, although we have some promising news coming forward in terms of vaccinations for this pandemic. But what we want to highlight here is even in the 1918 pandemic, African Americans were more likely to die in the 1918 flu epidemic than the Caucasian population, as was the Hispanic population. So why did this occur? Why do we have these same comparisons from 1918 to the current day? So I think in order to try and understand a little bit of that, we need to go backwards just for a moment. We need to look at a historic timeline, and we're going to utilize the one for African Americans, a group that has been legally disenfranchised for approximately 400 years. But I want to encourage you to think about the minorities in your community, and I want you to think about their history, because that's one of the first tools that we have that help us to move forward towards cultural competency, understanding the history. So the timeline kind of talks about 1619 to 1863, chattel slavery was legal in the United States. So that kind of sets the frame. Let's bring this home to California. And at that time, 1850, California was admitted to the Union as a free state, the 31st state coming into the Union. However, in order for them to come in as a free state, the overall United States had to accept more harsh fugitive slave laws. Those laws allowed for people who had been enslaved, if they escaped slavery, to be returned, setting up the parameters that this people and this group of people would forever and always be enslaved. That's a pretty significant thing. And it has impacted a us and has still continues to impact us as we move through 2020. So during this time, we're going to focus on the medical profession, although all institutions were impacted by this, that the physicians at that time would do experimental surgery on the slave population because there was a belief at that time that they did not experience pain in the same way as other human beings. So you see that starts to set up the parameters that move into how the medical profession dealt with enslaved people as subhuman. And so that's kind of the background, the backdrop that we have. This belief supported the narrative that allowed these atrocities to be performed on the enslaved people. And so the, excuse me, the Fugitive Slave Act indicated, again, people would forever and always be property and could be returned to their former enslaved situation. So there was no way out. This set of rules, laws, and regulations lasted for about 300 years. Now, the thing that we want to try and understand is we were talking about legal. The people in power to make the laws supported these laws. From 1865 till 1965, after the abolition of slavery, we had Jim Crow and Black codes. And these were codes that allowed for legal segregation in most states and in the provision of healthcare. So we're starting to talk about now how this history impacted the healthcare of people of color. This was a collection of laws that were developed immediately following the ratification of the 13th Amendment, giving freedom to 400 people who were formerly enslaved. These codes were supported by laws, customs, mores throughout the United States, even states that were not previously slaveholding states. For example, in 1851, one of the laws indicated no Black, mulatto, or person of Indian birth could give evidence for or against a white person. So again, we're starting to see that we are incorporating these codes into our laws. In 1854, the Supreme Court of California added Chinese persons to this. See, these are legal documents I'm talking about. The schools in California were segregated from 1860 to 1880. But look at some of the issues that they stated that, again, Negro, Mongolian, or Indians were required to attend separate schools. Now we're going to see some switches that happen. Also in 1880, the Separate School Act in California was repealed. However, in that same year, legal status, 1880, developed indicating it was illegal for a white person to marry a Negro, mulatto, or Mongolian. So you see, we've had the laws, social mores, and customs that supported segregation and separation. These statutes were on the books until 1945. Okay, so we're talking about how these laws and structures were a part of the legal system of government. The legal segregation developed this concept of an inferior population. These concepts and ideas were supported by the institutions. And again, that would be banking, housing, all of those institutions. However, today we're going to focus exactly on the medical institution because that's what's gotten us to this intersection where we are right now, the intersection of some of the social unrest that we're seeing and the disparity between the healthcare for the African American population. One of the most severe, or I think one of the most dreadful examples of this failure of the healthcare institutions to protect people of color was in the Tuskegee experiment. In 1932, this involved about 600 African American men and about 399 who had syphilis and about 200 who did not. The study was described to have some information that the people could gain around the long-term effect of syphilis. During that study in 1945, penicillin became available as the treatment of choice for syphilis. However, none of the participants in this study were offered that treatment. This medical experiment continued until 1972. This study is one of the most flagrant disregards for the life and welfare of people of color. Again, being influenced by many beliefs, ideas, and concerns that were put forth legally by the Jim Crow and Black Code laws. These instances have set up a distrust, as you can understand, between the African American population and the medical establishment. Historically, African Americans have received fewer resources for training of students to become healthcare professionals, and in many instances were denied admissions to medical training institutions. All of this was legal. This is what I want, because we got lawmakers here in the room, and these are some of the areas that you'll want to think about as you began looking at various kinds of legislation, various kinds of enactments of activities. That's what I think Dr. Salam was trying to say to us. The lack of medical facilities in African American communities and the lack of financial resources led to these health disparities. In some instances, because African Americans were not allowed to be serviced in the same areas of the white population, many of the maternity operations that would service African Americans were in the basement of some of the hospitals that service the majority population, in the basement or in scrub rooms or rooms that were not clean. So we have to understand that this distrust between the Latinx population and the African American population is based on historical beliefs and understanding and things that have happened. These disparities are particularly critical in California because of your large Latinx population. In reviewing this timeline regarding legal disenfranchisement, we understand that this was about 400 years, including both slavery and Jim Crow and Black codes. We have had less than 60 years since the passage of the Civil Rights Act in 1965 to deal with these issues. Again, understand these were legal issues, mores, and customs. And so if we look at these timelines and try and get some sense of how those have impacted both the majority population and the minority population, we began to get some understanding of why we have not made all of the corrections that we need to. And in what Dr. Salam says, in a call to action, these two things have now converged with the pandemic. The civil unrest and the clear healthcare disparities are now on display. We can see all of it. These two areas intersect when you quickly look at the timelines. The 244 years of chattel slavery, 2 years of Reconstruction, 100 years of Jim Crow and Black codes that dominated the laws in many states. And we've only had 55 years in legally outlawing racial segregation. So that's the legal part, but we have to understand, to be culturally competent, we have to realize that the laws don't change hearts and minds, as people would say. And so we're going to try to look at what, based on that quick step back in history, we're going to try to look at what we can do, what you can take away today in terms of this call to action. Cultural competency is a set of behaviors, values, and policies that may be developed by us personally, by the system in our counties, or at the organizational level, with the ability to constructively interact and work across cultures. In order to work across cultures, we need to understand the diverse cultures. And there are many component parts to those diverse cultures. We've talked only today about the healthcare, and Dr. Love is going to move us now into discussing some of the specifics around diversity, inclusion, and equity. Before he gets started, I do want to remind all of you to be sure and place your questions in the chat box. We will respond to all of the questions following the prepared materials. So Dr. Love.
Thank you, Ms. Sanders, for that great walk through history. I'm going to be turning now to current matters and looking at how we can think about the issues of diversity, equity, and inclusion in health and healthcare currently. So one of the things that Ms. Becton said initially, that I also have a background, actually a degree in electrical engineering. And so I have a lot of sort of music and sound and animation that I developed and wrote for this presentation. And for those who know me know that I am quite a bit of a nerd. Looking now specifically at what it means to have good health, physical health, as well as mental health, and the consequences of not having it. Just a couple of quick disclosures for myself and Ms. Sanders, for all of us, that we have no financial relationship. We're not trying to sell you any materials, books, pamphlets, or anything like that. That this material is presented strictly for informational purposes, that we are not coming here as anyone's therapist, doctor, nurse, that there may be a small bit of material that's used under the Fair Use Act, but that if you decide to reuse it, you have to make sure that you also have permission to do so. And finally, that we have made every effort to be as accurate, as transparent as possible, but please know that anything that's said needs to be, again, researched and perhaps updated. Can't move forward without acknowledging that by this point in the presentation, if it hasn't happened already, I imagine it may happen, that many of us may have developed some resistance to, or at best, ambivalence about the material that's being presented. And I want to acknowledge that concern that we might be questioning the value, the use of this kind of talk, the value of spending our time listening, hearing about these issues. Our hope is certainly that you find it useful, helpful, valuable, and worthwhile. But I also acknowledge that some may have that sort of moan moment of, really, again, are we going to hear more of this? Haven't we already had talks about that? Why these people meaning the agency, educational folks, why do they keep bringing this to our attention? Haven't we already had enough workshops? Or one might find at the bottom area there where thinking, this is just total BS and I'd rather just disconnect. Looking at the issue then more specifically of diversity, equity, and inclusion, starting with what it's not. We're not today talking about things that are quick or easy fixes. We're not talking in a way that is confrontational. We're not talking about fixing anyone. And we're not talking just about problems. We're also talking about solutions. We're not just talking about things that are trendy or fads right now either. What we are talking about is a beginning, a process that requires introspection, that is thought-provoking, and that offers us an opportunity for both long and short-term success. And that, again, we're talking about a journey, a process, a working together, and not particularly a destination. Intention, language, clarity, complexity. If we aren't clear on words and ideas, how can we be clear on the solutions? There's a lot, you've heard a lot of terms already. I am not a diversity, equity, and inclusion trainer. I am a practitioner, a medical practitioner. I am an executive. I've written or signed hundreds of policies and procedures and guidelines. And I know the importance of language. And I know that if we are not clear in our language, we can't have a conversation about these issues. We're not going to be able to develop or even formulate what the problem is. And if we can't formulate well the problem, we certainly can't formulate well the conclusion. I came to medical school having studied lots of different disciplines before getting to medical school. And there may be some who disagree with me, but not many. Med school was actually intellectually very easy. That there are fields that are much more complex, much more intellectually challenging, I found, than actually medicine. And not everyone would agree, but many in my class who had studied other fields would, even taking something as simple, if you will, as calculus, that everyone was required to get into medical school. Calculus was much more intellectually challenging than medicine was. What makes medicine difficult is the volume. And the only way to deal with volume is to have a system. And so I'm very particular in having systems for most everything I do. I have a system for when I see patients. I have a system when I think about writing or calling in a prescription, and I stick to that system whether the prescription or the patient is simple or complex. The system ensures that I take care of all the things that need to be addressed. I do it systematically, effectively, and efficiently, and make few mistakes. What I want to offer you by way of tools right now is when you enter in this conversation about health or healthcare, diversity, equity, and inclusion, to come up with a system. And well, I'm sharing with you my system of how I think about the issues. This may look like a complex slide, but I think I can break it down for you. Again, this is the system that I use to think about, to read papers when I hear presentations. The first thing that I do is I ask, are we talking about health or are we talking about health care? That's the first branch point, because they're not the same thing. Healthcare is certainly a part of health, but it's actually, if we look at the whole history of how we've gotten to our current longevity, healthcare has not been a significant part. Other things have been responsible for why we live now as long as we do. So I ask, whenever I'm beginning a conversation, whenever I'm reading a paper, whenever I'm thinking about problems or solutions, I ask first, are we talking about health or are we talking about healthcare? If we're talking about health, what aspect of health are we talking about? Are we talking about the economics, our physical environment, education, food, nutrition, individual behavior, biology, and genetics? I think that encompasses all, and the other part would be healthcare, but I think that encompasses all the aspects of health that can be addressed. So again, we divide it into health and healthcare. We say that we're talking about specifically within health, then what within health are we talking about? If we decide that we're talking about healthcare, then the branch point is, are we talking about the quantity of healthcare or the quality of healthcare? And if we're talking about the quality, then what aspect of the quality are we talking about? So it tells that I use this diagram all the time when I go to, like I said, to present, to think about these issues on my own, to read papers, because it's so easy to get caught up in confusing what we're looking at. Once we've decided sort of what branch we're on, then the issue is one of disparity. Disparity simply means a difference, that two things are not equal. So disparity and inequality are very much the same thing. One, you can take, for example, that over the course of a lifetime, about 1 in 9 men will develop prostate cancer. Over the course of their lifetime, 0 in 9 women will develop prostate cancer. There is a difference there. There's a disparity. There's an inequality. But I don't think anyone would ever argue that there is an inequity, that there is a sense of injustice, that there is a sense that some wrong was done or some good needs to be done. If we decide that there is an issue of inequity, I think it's important, even though we might not want to admit it, is to think about whose fault is it and whose responsibility is it to fix it. So again, this is one of the tools that I use. I first decide health or healthcare. Within each of those fields, where am I looking? Then deciding, are we talking about an inequality or an inequity? Here's another look at if we're talking about the issue of health. Again, I encourage you to consider which sort of column are you looking at in terms of the problem and the solution. This also helps to recognize that if you create a particular intervention, let's say in education, and it's unsuccessful, it might be unsuccessful because of these other columns. And if at least I use these to track everything that I do, to know that maybe my intervention in education was ineffective because there was a community or social context issue that I didn't address sufficiently. So, inequities: unnecessary, avoidable, unjust, unfair, or capricious. Differences in morbidity, mortality, prevalence of an illness or disease, and the incidence. That's how we might define health inequities. And bring us now into more specifically into the issue of medicine in particular. Let's talk about cardiovascular disease. If we look at the issue of heart failure in Caucasians versus African Americans, looking at a disparity, an inequality. If we look at fatal stroke, we also see a disparity. If we look at death from cardiovascular disease, we see about a 50% or 1.5 times disparity. If we look at end-stage kidney disease, we're looking at almost 5 times disparity. If we look at just death overall from hypertension, we're also looking at an extremely high disparity and an inequality. The next question, though, is there an inequity? We know that this represents an inequality. Is there an inequity?
We may consciously reject negative images and ideas associated with disadvantaged groups, and may belong to these groups ourselves, but we have all been immersed in cultures where these groups are constantly depicted in stereotyped and pejorative ways. Based on the available evidence, physicians and nurses manifest implicit bias to a similar degree as the general population. The current literature indicates that most physicians, regardless of specialty, demonstrate an implicit preference for white people. Laboratory experiments have persuasively shown that healthcare providers' decisions about patients are shaped by race, social class, and gender biases. 20 out of 25 assumption studies found that bias was evident either in the diagnosis, the treatment recommendations, the number of questions asked of the patient, the number of tests ordered, or other responses indicating bias against characteristics of the patient under examination. Psychotherapists are more likely to offer appointments to middle-class white people than to middle-class African Americans or to working-class people of any race. A black, working-class man would have to call 80 therapists. A middle-class white woman would only have to call 5. Although blacks have similar or lower rates of common mental disorders than whites, mental disorders are more severe, disabling, persistent, and if they receive care, it is usually of lower quality.
So now turning specifically to, we've looked at issues in medicine, now looking specifically in psychiatry. What do we know? We know for currently and historically that in communities of color, psychotic disorders, conduct disorders, and personality disorders are overdiagnosed as opposed to mood disorders. We know that if we do reviews of charts and medications given, that one is African Americans and other people of color are more often given older medications and at higher doses. If they come into a clinic visit complaining about side effects or requesting changes, again, chart reviews show that either it's not noted at all that there were any complaints, or it's about 60% more likely that no changes will be made. In addition to that, for those who go into psychiatrists, they are rarely offered psychotherapy as an option as opposed to just medication. Finally, at the bottom there are all sorts of medical conditions that can mimic psychiatric disorders. If we look at charts, we see that very few lab tests are ordered or other studies ordered. Again, if we look overall within psychiatry, that those from the Hispanic community and from the African American community, less likely to achieve remission. They will be treated, but less likely to achieve remission. It's more likely that they will be on permanent disability. And not surprisingly, there is a pervasive distrust of the system and a pervasive lack, for the most part, of Hispanic or African Americans entering into research studies. There's not surprisingly service disengagement. And finally, for many people, the way that they ever actually encounter psychiatry, mental health, is in a non-ideal manner, meaning that they are not showing up on their own voluntarily, but they are coming through the school to prison system, an involuntary hospitalization, the child welfare system, or the correctional system. Turning now, where do we go from here? Roberta talked about intentional harm and historical discrimination. I'm talking more now about the unintentional, that when we are people of goodwill and good care, where it's not in any way our intention to discriminate, but perhaps some of the things that we are doing or the ways that we are thinking end up in fact discriminating. Begin the top left for me with the San Francisco Fire Department. They, for the longest, had a height requirement for firemen. They had a height requirement, I don't remember, it was a little over 6 feet, which sort of makes sense. You would want your fire people to be, firemen and women to be strong and healthy and to be able to carry people. What that did, though, in a city like San Francisco is, not surprisingly, you ended up with very, very few Asian fire people. And so a practice that was not meant to be discriminatory because of the physical characteristic actually ended up discriminating. When they realized that strength and agility are what's required, that height really didn't matter nearly as much as they thought. Also along that top row, you may have seen this sign at airports or in your community or lots of other places I've seen this sign around. If you see something, say something. lots of studies have shown that where the sign has been in place, excuse me, most of the calls that were placed to law enforcement were for Hispanic or African American, for Black people when this sign was present. One researcher out of Northwestern University in Chicago found that she did an experiment, and what she found was that a simple change to this sign, instead of if you see something, say something, it was changed to if you see something suspicious, say something specific. That simple change decreased the number of calls about Hispanics and African Americans by 70%. If you see something suspicious, not if you see someone suspicious, if you see something suspicious, say something specific. So a simple change in signage can make a difference. On the bottom there, hello, my name is. It has long been known that in the academic community, in medicine, in research, that the first author on a paper matters. That if the first author on a paper that's sent into a journal was a female name, that they were 35 to 40% less likely to be accepted. If the first author's name was something quote unquote foreign, they were also less likely to be accepted. If the name was something that one might more easily or call stereotypically Black, African American, where you could guess the person's race, the paper was also less likely to be accepted. And so you'll see in many journals, all they have is initials. First initial, maybe middle initial, and last name, because they don't want the person to be easily identified by at least by gender. And sometimes they'll even change up the last name, or with many of the journals in medicine, it's submitted completely anonymously. So you don't know, you might know the institution that they're from, but not their name. So you can't discriminate against someone who has a foreign sounding name. So again, we looked at something physical characteristics that might be embedded in policy that can end up being discriminatory. A signage that we think of as pretty benign can end up being discriminatory. The issue of naming and how we might de-identify, and then so that we are better fair in our assessments. Finally, at the bottom there on the bottom left, I'm thinking about working from home. All of us maybe are a bit tired, I would suspect, I know I am, from working from home. And in some ways, though, we are very blessed in that we can work from home. However, we know that many of our people who are on the front lines, our office assistants, are from the Hispanic community or the African American community. Working from home for them may not be a very good option. That might not have facilities set up to allow that. Home care may not allow that. Being home a lot more also means that one's heating bills, cooling bills are a lot higher. And so something that we think of as a good thing, we'll give people computers, and we forget that not everyone might have Wi-Fi. Or if they actually do have Wi-Fi at home, they might actually not have very good or fast Wi-Fi. And so our intention was not to be discriminatory, but because the frontline population might be from communities of color, things that we can take for granted might actually end up being quite harmful for them. Where do we go from here? Part 2. I'd like us to consider thinking about diversity competency. We talked about cultural competency. I asked us to consider also diversity competency, which asks us to think about self-awareness. It's about humility in many ways. It's about being willing to recognize that life is complex and difficult and challenging, and a willingness to learn from and listen to from others. Okay, final 2, I give you, again, I talked about the system that I use quite all the time when I'm thinking about issues of diversity, equity, inclusion in health or healthcare. I offer you another system, another way tool to think about specifically doing these things by steps. Know your baseline, and not just knowing it, but actually having a measurable baseline, quantifying it, identifying specific indicators that one is going to select that will let one know that one is being successful. Then specifically along the way, not just at the end, but along the way, deciding how you're going to measure and publish success. Point 4 there is make sure to include not only the people who are like-minded, but the people who are not like-minded, the people who are actually going to be most impacted by any change that we are going to make or any policy procedure guideline that we're going to put in place. And then finally, to have leadership commitment. All right, thank you for your time and attention. And we are going to now open it to questions. Hopefully in chat, everyone's been putting in their questions. I believe Jocelyn is going to help with that.
Hello, everyone. Thank you, Dr. Love and Roberta. At this time, we will give you guys a few minutes to place any and all questions in the chat. They are anonymous, so when you do send them in, we will answer them. We will not say, who they're from, and then we can address them that way. So we will give you about 2 or 3 minutes to come up with your questions and place them in the chat, and then we will address them as they come in. Thank you. Okay, so we do have a lot of questions coming in. So what we're going to do is we're going to start addressing them. And then as you guys have more questions, you can just put them in the chat. The first question we have is, how do you address these issues among elected officials who are not bound by the same rules as employees?
Roberta, you want to take that?
Yeah, I can take that one. Our primary audience that we have been talking with in the past have been actually healthcare professionals. However, because in March, when we went virtual, we have noticed that we've been picking up lots of people from various disciplines. I think Ms. Becton indicated earlier, we had people from the FBI and several administrators. So, and also people in law enforcement. So not as much in terms of council people or people who actually make laws, but we have had people from various disciplines. So this is one of our first formal opportunities to talk with those of you who make the laws and those kinds of things. So we really appreciate that. We also, I failed to say when I started, want to thank you. I don't think we say that often enough to public officials in terms of the hard work that they do in terms of keeping all our counties and communities moving forward.
Yeah. I also want to just say one thing too, and we'll pass that information on to the CSAC group once we launch that. But next year, we're going to be doing a collaboration with Northwestern and Kellogg around executive leadership training as counties prepare in states, other states. We're not going to just stay in California, but that is our main focus, California. But we're going to bring some real tools, and we're going to start launching in, I believe, February. We'll share that information so people can know about that, and send different people. It starts at the highest level, and that's why we decided to partner up with Northwestern and Kellogg so that we can bring really good materials that are inclusive and people really want to understand and get and move forward and apply it into your programs, whether it's CBOs or other communities, and it's not just African American specific. So I think it's great, and we're looking forward to it. So I just want to put that out there for folks as well.
Perfect. Thank you, Nisha. So our next question is, what indicators of success are suggested to be tracked? Dr. Love, do you want to take this one?
Sure. Certainly one, it really is up to the county and your decisions about where the greatest disparities lie, and pick something that's actually measurable and that you can actually make an impact on. Not everything that's can be attacked easily or readily or can be measured. I think about one effort that looked at the rate of return for a second visit. Why was it that although we were seeing lots of people, say from the Hispanic community, African American community, LGBTQ community, coming in for mental health care for an initial assessment, but we were noticing that there were very few who were actually returning for a second visit. So we decided that was one indicator, thinking, well, maybe there was what was happening in that first visit that discouraged people from returning again. Another measure of success might be looking at to what degree does the diversity of the staff match the patient, in physician, I'll use the term patient, the patient population. To what degree does not just the staff, but even more particularly the leadership match, at least approximate the population served. But again, it's hard to say what, in terms of what particular measure to pick, but pick a couple that are quantifiable and that you can assess whether you're being successful or failing at.
Okay, thank you, Dr. Love. The next question is, can you give a real world specific example of when you see something suspicious, say something specific? I think Dr. Love, this one is also for you.
So I will make it very crass in some ways. I mean, if you see someone with a gun walking up and down the street or holding it up, pointing it at people, if you see someone waving a knife, then when you call, you give a specific description of what's seen, not just the person's ethnicity or gender, but you say what they are doing that is causing alarm. Yeah, I'll leave it at that. I don't know if others want to give another example.
Okay, thank you, Dr. Love. The next question we have is, are there specific policy changes or laws that counties should examine to reduce disparities? And thank you for the excellent presentations.
Roberta, you want to take that one?
Yeah, I can take that one. I think the thing that you want to do is you want to look at policies, procedures that you are, because right now you're being asked to look at a very different environment, an environment we have not been in. None of us were here in 1918. So we want to look at our communities. One of the first things you need to understand is, what are the diverse pieces of your community? And then, because there's a lot of data now, we're fortunate, what are the diversities in terms of healthcare? So as you're looking to, let's say, fill in the blank, fund the local county hospital, do you want to look at that through some diversity and equity lens? Do you want to see what the leadership at that hospital looks like? What does their staffing look like? What does their patient group look like? Is there any matchup between who they're seeing, their clients, and who is offering the service? Who submitted the requests for funding? Do they mention anything about the diverse population that they're seeing? So I think those are just some of the kinds of lens you want to utilize when you're thinking about funding. And maybe some of these are community-based organizations that do some of the work that the county is obviously charged with, making sure that the recipients in the county get this service. But are we looking at that through any kind of diverse lens? And are we making sure that we're measuring for the total population, maybe not just the majority population?
I would add to that, I know that in my first position, my first leadership position after residency, uh, one of the first policies that I had to write was a policy about how to write policies. And that might be a good place to start, because what it says is that this is going to be the standard for all our policies, at least from this point forward. And so all policies, no matter what area, will have to take into consideration these particular issues of diversity, equity, and inclusion. And that way you don't have to go through and just kind of sort of pick out because I mean, I'm sure we've got thousands upon thousands of policies. It would be, I don't know how we could decide which ones to want to look at more specifically, but maybe keeping our ears open to what people are saying and being willing to take seriously when someone says, I'm being unfair, or at least it feels like I'm being unfairly singled out or discriminated against, even maybe unintentionally, but be willing to listen to that. So again, maybe go back and now think about rewriting your policy on how to write policies.
Perfect. Thank you, guys. The next question we have is, during the pandemic, have you seen minority communities more adversely affected? And what are your thoughts on the long-term consequences or effects this will have in our communities? Dr. Love, did you want to take this one?
I'll maybe let Roberta start, or maybe Ms.
Okay.
Beckman if you want to start.
Okay.
Yes, obviously we have seen many issues related to disparity as we have moved into the pandemic. As we've moved into telehealth, one of the things that we've noticed at the clinic is there's kind of, I think it's like Dr. Love was saying, an assumption that everyone has a private space in their home where they can take a personal call around their mental health and their mental health services. For families that live in multi-generational homes, and the fact that people are home now, that may not be true. So yes, that does create some of the disparity, particularly, as I say, in those multi-generational homes where there just isn't private space to conduct a mental health visit on the telephone. And so that has definitely been a challenge for some of our clients.
Long term, I know I worry a great deal about all communities. And we began with a talking that talked about the 3 to 5-fold difference in either infectivity or death in the African American community. But I worry also now about all the significant delays in care that have occurred because people are not going in to see their primary care provider, their pediatrician. And so they're not getting the appropriate, I mean, we're certainly hoping for a COVID-19 vaccination, but we're also seeing, excuse me, kids not getting their appropriate on-time vaccinations. We're not seeing adults getting the appropriate vaccinations. We're not seeing those with diabetes or hypertension having the appropriate follow-up. On the mental health side, we're not seeing people going to the laboratory, even being able to find an open laboratory where they can get their blood drawn. We're seeing lots of centers where you have to have a negative COVID test before you can see a specialist. And so there's huge delays before you actually get in for care. And without a doubt, once we are on this other side of the pandemic, and I've talked a lot with my other primary care colleagues, we have a real fear about seeing lots of advanced cases of uncontrolled diabetes, uncontrolled hypertension, untreated hepatitis B or C, untreated, unaddressed HIV because of delays in treatment.
Thank you, Dr. Love. The next statement that we do have is, as you develop and deliver content to elected officials, please include tools for accountability. We can make all the policies we want, preach it, but we do not want to demonstrate practice over policy. Effective long-term sustainable change does not happen. Thank you for that statement. The next question we have is, I think, Roberta, this one is for you.
Yes, okay.
The question is, the historical timeline presented taught in California curriculum? If not, are there plans to advocate for inclusion?
I'm not sure because I'm not in education, but I would doubt very seriously that that timeline that we put forth is taught in the California curriculum. However, for us to all kind of get started so we can be culturally competent, I certainly agree with you that we should begin to have some of that kind of very authentic educational activity so that we're at least all kind of starting at the same place. It helps us to be able to talk with each other. And we are currently at 142.
Perfect. Thank you, Roberta. The next question we have is, fundamentally, I believe we need more broader representation in elected office to expand the lens and lived experience of decision makers. Are there specific policies that you recommend to support electing a more diverse board? Who wants to take a stab at that one?
Ms. Becton?
Yeah, in terms of elections, I think one of the things is, again, some time back, we actually took some of the civic classes and that out of our educational curriculum. And I think one of the things that has to happen is we've got to reintroduce those so that people understand that the government only works as well as the people in the government. And so we've got to encourage young people to think about careers in government and that it is not all negative. Some of the negative campaigning and those kinds of things that have happened over the last few years, I think has discouraged young people of color or the majority population of going into politics. So I think we all have to work certainly at our community level to talk about the positive things that you are able to do and the changes you are able to affect if you do consider going into politics. So that's for all communities, and then even more so for communities of color.
I think the other thing I would add is to think about where we are advertising. That like one job I had in California, someone came to me and said, did you know that of the last 5 doctors you've hired, they're all from University of Chicago? And even though we're in California, there are some good doctors in California. And what I realized is my circle of influence was really at the University of Chicago. Those were the people I know. I could vouch for them. If we got on a Zoom call, if I was interviewing them, they could talk about, hey, do you remember when we were at Regenstein Library? And so there was a connection. So where is it that we're actually looking to bring in people into becoming on the Board of Supervisors, to be entering into elected government? Where are we actually asking, how are we presenting it? And then I guess the other thing I would say is actually, someone talked about accountability. One way of accountability is to actually assign some people. You are to mentor this group of people, this person, this school. You are going to be the mentor. And at the end of the year, we want to have 3 interns from that school. And you have, the way you hold them accountable is you assign them.
Thank you, Dr. Love. The next statement we have is, I just wanted to say thank you to the CSAC for offering this workshop and engaging counties in this conversation. It is not an easy one to have, but is essential if we are going to make progress. I think those are all of the questions that we have for now. Hear me? Can you hear me?
Yes.
Okay, the last statement that we have says, I just wanted to say thank you to CSAC for offering this workshop and engaging counties in this conversation. It is not an easy one to have, but it is essential if we are going to make progress.
Thank you. Thank you. We also want to just put out there, if you have any additional questions, please feel free to leave them later in the chat or pass them on to CSAC, and we'll be more than happy to answer them and send those answers to them. If any counties need additional resources around this, please send that through CSAC and we'll get resources. So we're very pleased to put this on. I realize it was a short presentation, so we tried to kind of put everything in 90 minutes, but we enjoyed it and we hope that you found something helpful. And I'm excited about it, just to know that the state of California officials, elected officials come together and get these types of trainings. I think it's wonderful. I'm born and raised in California, living in the Bay, but from Orange County. So I'm really excited about this and hope to see everybody in the future. Take care, be safe, and get your rest. We talk about long-term effects. I think that we all have to pace ourselves, because I happen to believe we work even harder from Zoom and from home, and raising kids. And keep your eyes on your neighbors, your kids, and other people out in the communities, because the suicide rate is absolutely high. It is real. I had an experience a month or so ago. My son's roommate in college at USC committed suicide. So it's real, it's there. So let's just all try to watch over each other and keep our eyes open. Stay woke, as the kids would say. Thank you so much.